Ladies and gentlemen, welcome back to the London conference. Delighted to have you back with us today, and hope you're all nicely refreshed after the lovely dinner last night, and that you've had a nice relaxed night's sleep, perhaps a more relaxed night's sleep than our Prime Minister did last night. So welcome back to the London conference. And this morning we're going to be talking for the next hour in here about health and a very important health development. Yesterday, those of you who were at the dinner would have heard Robin obviously talking about the terrible situation the world finds itself in at the moment, the various crises going on. COVID and the food crisis, and of course the conflict, the energy crisis. And he said that he was sort of leaving, sort of feeling some degree of trepidation about the future of the world, and I think a real concern about the lack of multilateral cooperation on a number of these issues. So one can't help feel a bit sort of depressed and worried about this situation. But we're going to sort of very much try on this second day and today look more optimistically to the future and sort of using this well-known saying, never waste a good crisis, which is actually often attributed to Winston Churchill, but apparently wasn't Churchill at all who said that. It was an American political strategist working for President Clinton who was sort of saying that you never waste a good crisis and you can turn it to your advantage. And our health programme, the Centre for Universal Health at Chatham House, is reflecting that so many of the world's great universal health systems have actually come out of crises. You know, just at the time when you think it's sort of least likely to happen, if you look through the history of our country here in the United Kingdom, Japan and Thailand, it's times like this that you actually see these transitions to a universal health system. So we're delighted to be launching a commission for universal health that is going to be doing research looking at these transitions through history and seeing whether they might be relevant to the crisis-ridden world of this decade. And absolutely thrilled to have 36 commissioners now and 2 wonderful chairs who are going to be leading the commission. And it is our official launch today. We had one of the commissioners' meetings last week, but it's our official launch today. And I'm absolutely thrilled to have with me on the panel the Right Honourable Helen Clark, who is the former Prime Minister of New Zealand and is one of our co-chairs. And hopefully joining us is, there he is, marvellous, bang on time, is former President Kikwete, Jakaya Kikwete from Tanzania, who's dialed in today from Dar es Salaam. They're co-chairing our commission, and we're delighted that, given all their expertise as former heads of government, that that they have all this sort of knowledge about how these reforms have been important to their countries. And we thought we'd introduce you to one of our commissioners. And given that the focus of our work is looking at crises catalyzing health reforms, really who better to have than the former Minister of Health of Ukraine, Dr. Ulana Suprun, who introduced some very impressive universal health reforms, really in the aftermath of the first major conflict in 2014 in Ukraine, and she's going to be telling us in a few moments about those reforms. I need to remind you that we are on the record today, so please do tweet. And we're really keen to make a lot of noise about the Commission. So do please share that with your friends and colleagues. So you're on the record, and this session is being recorded as well. We've got a large online audience as well today who are going to be asking questions. We're going to be having some introductory remarks from our panelists, but we do really want this to be an interactive session. And in particular, we're keen to sort of talk to you about where might in the world there be the opportunity for these crises to catalyse health reforms going forward. So that's enough from me, and if I can hand over to Helen now. So Helen, why have you got involved in this project, and what are your expectations for the Commission for Universal Health?
Well, firstly, it's great to be involved with President Kikwete co-chairing it. We go back a lot of years to when we were Commonwealth leaders, and I guess we've both got a bit of an eye on Kigali this weekend when the CHOGM meets there. But, you know, I come from a country which is a classic of the model of universal health coming out of crisis. And if you think of, you know, the really tough years of World War I, the men, it was largely men, and the few nurses who came back from the war almost immediately plunged into another post-war recession. Country staggers on to the late 20s. There's the Wall Street crash. And families were impoverished by the Great Depression. And the government came to power in 1935 very much focused on rebuilding human security and social protection. And one of the great innovations out of that was the 1938 Social Security Act, which provided for comprehensive universal basic social protection and also for universal free healthcare. So to this day, the New Zealand hospitals are free of charge to anyone who walks in with any condition. There's a very minor charge on the first 20 prescription items. You get a year, $5 New Zealand dollars, which is about £2. After that, free. And primary health care began as free, although I regret to say that the New Zealand branch of the British Medical Association, which was active in New Zealand, campaigned vigorously for the right to impose a co-charge, and over time that became burdensome. And my government and other governments from time to time have worked to knock back the primary care charge to nothing for increasing groups from the elderly to children and so on. So that was our history, that a government came saying, out of the depths of despond, we have to do something better for people. And it was really build back better before anyone ever thought of that phrase. Build back better got currency after the Boxing Day tsunami in Southeast Asia, but it's become a bit of a catch cry for coming out of crises, addressing some of the more fundamental issues. So I think if the Commission can look at these case studies, and you don't have to go back to the 1930s or 1945 NHS for them. There's much more recent examples, as you say, but really inspire countries as they try to reset at a time of a syndemic of challenges, multiple crises. We have the three big C's of climate change, COVID, which is still with us, and conflict, all hugely unsettling people. And I think that politicians, if inspired to go down this track, will see that there is a yearning for human security, for not being completely flattened by adversity to the extent that you just cannot access the health services that you need. I think it's good that we've called it universal health, because health is more than health services. I was a health minister once, and I used to say that health is not to be found in the doctor's rooms, the hospital ward, or the pharmacy. Health, as the Almaty Declaration reminded us, is a state of overall physical and mental well-being, which is conditioned by whether you have adequate income, nutrition, education, service access, of course, whether you live in a clean environment, and whether you live in peace. And if you don't have those things, as we see in Ukraine today on the peace front, everything's unsettled. So I think we will have a broader focus than just services, which is good. And my last point, Rob, would be to recall that when we entered the COVID-19 pandemic, most of our health systems were not prepared for that. And had to adapt extremely rapidly. Most had neglected their public health infrastructure and their capacity for the test, trace, isolate. We had to really run to try and catch up. And we saw the disproportionate burden of disease on not only the elderly, but also those with health vulnerabilities a lot of which were from the non-communicable diseases, many of which we can do something about preventing. So I think in our universal health vision, we should look at this too.
Definitely, yeah, yeah. And I think you're absolutely right that, you know, we are looking at the complete broad spectrum of what we regard as health and health reforms, health services. And I think it's unfortunate that sometimes the terminology has tripped us up a bit. You know, you hear a lot of talk about universal health coverage and people associate that with insurance coverage and hospitals. But, you know, the whole raison d'etre behind the Commission is that we look at health in its entirety. President Kikwete, if I can come to you in Dar es Salaam, and perhaps if you can give us your thoughts, as you know, I know you've done a lot of work on access to health and education services, in particular through the United Nations recently. But what's attracting you to co-chair our Commission, and what are your expectations?
Well, greetings from Dar es Salaam to Helen, to Ulana, to Yates, and to fellow commissioners. But let me say I'm delighted to join today the Chatham House conference and to be co-chairing the Commission for Universal Health with my colleague, Right Honorable Helen Clark, former Prime Minister of New Zealand. Because as Helen has just mentioned, the world has not performed well in tackling the COVID-19 pandemic, and in particular, there has been alarming lack of solidarity between rich countries and the developing nations, especially in terms of guaranteeing universal access to essential life-saving vaccines, tests, and medicine. It was just over a year ago that the UK hosted the G7, where Helen Clark's independent review made explicit recommendations to rich nations to share vaccines, fund COVAX properly, and accelerate the transfer of vaccine technologies to poor nations. But sadly, these clear asks to help end the pandemic somehow fell on deaf ears, if I may use those words. Even the modest commitments to reallocate vaccines haven't materialized, and wealthy nations continue to block attempts by developing nations to secure necessary technology and know-how to make their own vaccines. This is not the first time developing nations have been let down, because many of their health systems have been undermined by inappropriate development policies of the 1980s, 1990s, imposed by international financial institutions and donors. These forced them to cut public health spending and push the financial burden onto households through charging them user fees. You remember the structure adjustment programs of the 1990s. Is it any surprise, therefore, that millions of our poorer citizens continue to struggle to access vital health services? Anyway, looking ahead, perhaps the COVID-19 pandemic might prove a turning point, because I feel that many leaders, especially in Africa, are increasingly recognizing that we can't rely on international aid to achieve universal health coverage, and instead we need to focus more on domestic financing reforms. Now, some might say, what is the likelihood that countries will be able to find necessary public financing to launch ambitious health reforms in the midst of all the crises besetting the world at the present? And Helen very aptly described the 3 C's: climate change, COVID, and conflict. But it is the thinking behind our commission that throughout history it has been shown that it's during periods of crisis that universal health reforms tend to occur. For example, both the UK and Japan launched their successful universal health systems when they were affected by effects of post-conflict after World War II. Also, Thailand launched its universal health system in the aftermath of the massive Asian financial crisis in the turn of the century. Interestingly, the World Bank's advice at the time to incoming Prime Minister was that the country could not afford these reforms. But Prime Minister Thaksin stuck to his guns. And now Thailand has a world-famous universal health system which performed extremely well throughout the pandemic. The main focus of our commission is going to be to study the impact of crisis on health reforms throughout history, but also to look forward and ask, where might the crisis of early 2020s catalyze a new generation of universal health systems? And to inform this process, we have assembled an extraordinary group of commissioners, many of whom have direct experiences of these processes, and in some instances have been actual architects of their universal health systems. For example, Thailand, Mexico, Cyprus. We're our fellow panelists today, Ulana from Ukraine. Ladies and gentlemen, it is our sincere hope that we can draw on the experience and knowledge to learn key lessons from these transitions, which we can share with today's political leaders to encourage them to launch a new generation of universal health reforms. We will have a great opportunity to do this when we publish our report at the United Nations high-level meeting on universal health coverage at the General Assembly next September 2023. Were we to influence the advice, just one leader to implement the type of health reforms that have benefited other countries emerging from previous crises, we think this would be a tremendous achievement. And we are hoping our positive messages will help countries at all income levels to accelerate progress towards universal health coverage and enable them to achieve the health-related sustainable development goal. Ladies and gentlemen, thank you for your kind attention. Let that be my words at the beginning.
Fantastic. Thank you so much, President Kikwete. That was excellent. Thank you. And I do think it's very interesting, you mentioning the emphasis on domestic health financing reforms. And I think a number of leaders sort of recognizing, that this really is the case for them using predominantly domestic financing. I know that President Kagame has been very vocal in saying this when he was chairing the African Union. He was making this point that you just made, that we can't rely on international aid anymore, and we really have to do this ourselves more. So I'm sure this will be a topic that he'll be discussing at CHOGM this week. You also mentioned that we have one of our commissioners who has got perhaps the most recent experience of implementing universal health reforms in a time of crisis. And we're absolutely delighted to have on the panel today who has undertaken a phenomenal journey to get here from Kyiv to talk to us today, Ulana Suprun. So, Ulana, can you sort of give us your thoughts on what you did? Why did Ukraine do what it did under your leadership, 2016 to 2018, and perhaps the implications going forward as well?
Thank you very much for inviting me today. I'm very proud to represent Ukraine at Chatham House. I saw that Ukraine was quite the subject in many of the panels, and I'm glad that we have retained the interest of the international community in our fight for our independence. I'm also thrilled to be on the commission. I have to tell you that we had our first meeting, our Zoom meeting, and you had 35 commissioners, each of which was supposed to introduce themselves in 1 or 2 minutes. Obviously, it lasted about 2 hours because everyone had a lot to talk about. They have their stories to tell. And I myself wrote down some notes so that I could talk a little bit less than what I would want to, which probably would be about 3 or 4 hours about all of the changes that we did in the healthcare system in Ukraine. So this is the first time that I'm outside of Ukraine since February 23rd, when Russia had its all-out invasion of Ukraine. And for me, it's been a bit difficult to adjust because the environment, what's been going on in Ukraine is hard to take every day. For instance, yesterday I found out that one of the writers in our organization who's serving in the Ukrainian military was injured, and another person in his unit was killed, and a third lost his leg. So we're dealing with that and sirens and attacks every day. So please keep your attention on Ukraine and keep us high in the media as well as in the discussions that you have in Chatham House. The Commission's primary purpose is to encourage and ensure political leaders to launch universal health reforms emerging from the COVID crisis. And as we heard, many healthcare reforms actually were initiated after some sort of a crisis. Ours were, our healthcare reforms, or the introduction of universal health in Ukraine, happened in 2016, which was 2 years after Russia's invasion of Crimea and East Ukraine. It was in response to the fact that we had 1.5 million displaced persons internally inside Ukraine. Now, when we started our healthcare reform, actually we have a member of the Strategic Advisory Group that came up with the technical part of healthcare reform. How will we change financing? How will that improve healthcare? That was the easy part. I'm sure that we all agree, those who have gone through this process, that the implementation of it, the finding the political will to actually do the healthcare reform and convincing your Minister of Finance to finance this healthcare reform is the more difficult part. And we often at conferences such as this discuss the technical aspect of it, but we don't talk about the political aspect or the challenges that we face. We face very many challenges, and it doesn't have to do with, do we pick a NHS system, or do we pick the Israeli system, or do we pick the Swedish system? It's how do we convince people that this is necessary, the general public as well as the politicians that we work with. Many of you discussed today that National Health Service here in the UK started after World War II, but we didn't talk about the challenges that Nye Bevan challenged when he was called the health Nazi, and that the healthcare reforms were Nazi reforms that were being introduced into the UK. That's something that I have close to my heart, because 1 week after I came into the Ministry of Health, there was the largest independent union of medical workers brought a gallows outside of the ministry and were protesting against the Nazi healthcare reforms that I was proposing with my team. So it's those kinds of issues that we often don't talk about. The communication, the fact that the massive disinformation campaigns that occur about healthcare reform. In Ukraine, on top of the vested interests of pharmaceutical companies and the corrupt medical community that existed, was compounded by Russian disinformation, which was aimed at the Ukrainian government against any reforms that were aimed at improving the life of Ukrainians, the lives of Ukrainians. Because, as we said, you cannot develop as a nation, you can't develop as a country unless you have enough food, unless you have healthcare reform, and you feel the need for development. One of the things that the disinformation attacks the most is trust in government. Why is the NHS the most respected organization in the UK? Because of the trust that the system works, that if you become ill, you will get health care, that you have that guarantee. And the disinformation war against Ukraine and against very many other countries that the Russians have initiated over very many years including the divisions that are happening in our societies, whether it's in the United States or here, has really hit that most important aspect of liberal democracies, and that is trust in the institutions. Yesterday, somebody said faith in institutions, and I think that that's wrong. You have faith in something that you're not sure if it exists, that you can't prove. We have trust in institutions because they do exist, and we trust that they will do their jobs. So our biggest battle in Ukraine was not even convincing the political institutions, because our Prime Minister and our Minister of Health, they supported the healthcare reforms. We fought against the disinformation campaigns, one of which was that I had closed hundreds of hospitals with healthcare reform. The truth of the matter is not a single hospital was closed. Hospital networks were formed, and we retasked medical institutions that were perhaps redundant in providing services to provide different types of services. There are very few addiction treatment facilities, there are very few rehabilitation centers, long-term care facilities in Ukraine. So we took those hospitals or medical facilities that were no longer necessary for the population and retasked them to do different jobs. Those are the kinds of things that when we started doing healthcare reform, nobody told us about. Nobody helped us with that. And I think that if we had understood those challenges in front of us, and I'm only talking about one of the challenges, there are very many, we may have been able to plan for it. We did end up having a very successful communication campaign. We did end up actually almost failing in our success, because we were told by the WHO that in our first year, if we had signed up 10 million Ukrainians to their primary care physicians, that for the first time they had a free choice choosing their physician rather than it being assigned to them by their place of residence, that if we had signed up 10 million of our citizens to their primary care physicians, it would have been a massive success. So when we planned the budget for the following year, we planned for 10 million already signed up and an additional 10 million signing up over the course of the next year. Lo and behold, by the end of the first year, 20 million people had signed up to healthcare. So we didn't have enough funding in the budget to pay for primary care for the next year, and we had to do a lot of moving around of money to get it done, but there was the understanding of our financial minister to help us do that. So I was quite impressed by the number of people and the experience that the commission has, but the reason that I agreed to be on the commission is because I wish this commission existed when we were doing healthcare reform. I wish that I could have sat with those 35 unbelievably experienced and intelligent and having great ideas people that are on the commission who could have helped us make it a little bit easier for us to make it through. And I think the fact that there's a practical component to this where two countries will be handheld to try to get as close to universal health as possible by the end of the existence of our commission, which is 3 years, that there's actually a practical result coming from it, not just a report that will be coming out that perhaps would read well, but won't actually be helping people and individuals as well as those that are doing universal health reforms. A little bit about what's happening in Ukraine right now. Yesterday we had a couple of pieces of good news, not within Ukraine, but about Ukraine. One is, of course, that Ukraine has now been granted candidacy into the European Union, along with Moldova, and we saw Moldova's president yesterday, so both our presidents are quite happy. And then the second thing, which maybe some people have not seen, is that the US Senate's Foreign Relations Committee has recommended to Secretary of State Blinken for Russia to be named a state sponsor of terrorism. What does that do? That kicks in a whole set of sanctions which have not yet kicked in against Russia, which hopefully will have some effect when it comes to the war in Ukraine. I've been asked how the war has impacted health. Obviously, it has dramatically impacted the ability to provide health care. There's about 650 healthcare facilities that have been damaged. About 178 of them have been completely destroyed. Some of those are in the liberated areas where there are now people returning and they do not have access to health facilities. So we've been working with international organizations and really very, very much working on our own inside Ukraine, and we're providing mobile primary health units going into the liberated areas to provide primary health services. 50% of the pharmacies aren't working. That's 50% of people who take medicines chronically that don't have access to getting those medicines. So the Ministry of Health has now tasked hospitals and healthcare facilities to hand out the medicines, the ones that have been provided as humanitarian aid, and the remainder of the people, there is now an online source of what pharmacy in your neighborhood has what medicines in it so that you can go and get your medicines. We do have a reimbursement program for medicines, so people are not paying out of pocket. That's something that also is part of our healthcare reform. And then the last part is, I was asked about the actual healthcare workers. Is there a lack of healthcare workers? Well, 20% of Ukraine is now under occupation, and many of those healthcare workers have left that area, moved into unoccupied territories. At this point, there isn't a lack of physicians, but there is a lack of nursing staff. Another issue that, has there been a lack of healthcare services provided? Well, 7 million people have left the country. So since our population has shrunk, the needs of society have shrunk as well. Unfortunately, when I was in Kyiv in the first couple weeks, in about the third week when the Russian forces had retreated, the businesses started opening up, and the first things that opened, the first businesses that opened were pharmacies. And there were long lines outside of the pharmacies, and it was chronically ill, elderly people who could not evacuate because they had nowhere to go or they had no one to take them. And they were the ones that were left behind, and I'm proud to say that Ukraine has been taking care of them. Civil society has been wonderful. There's so many volunteer organizations that would deliver medicines actually to people's houses, deliver food to elderly people's houses. So the Ukrainians have truly come together during this crisis, and we were lucky enough to have gone through our health reform in 2016 through 2019 before COVID and before this crisis, so that we were much more resilient and able to respond. We're a success story, surprisingly, to show that you can have a resilient universal health system in the 21st century. It works. So let's try to do this in more countries.
Yeah, yeah. And I think what you've also demonstrated on it is that you can do these things surprisingly quickly. That
Yes.
sort of people often think health systems take ages and ages to change, but what you achieved in 2 years was quite remarkable, and we really congratulate you for that. And sort of particularly what you sort of mentioned about creating this family doctor system so everyone can get to a doctor. You didn't even really touch upon the, sort of tackling all the corruption in the pharmaceutical procurement, which was an enormous issue in Ukraine as well. And we just know that there are countries dying to learn these lessons, and I think you make a very important point as well, that we in the global health community aren't very good at addressing the political issues. We sort of make out it's always a sort of a technical issue, and you do costing exercises and stuff like that. But really what leaders like yourselves and heads of government are looking for is advice about the political strategies, the costs and benefits of different things. And this is very much the idea of the Commission, to bring together people like yourselves who have done this and work with people who are aspiring to do similar things in this crisis-ridden world. I'm going to actually go straight to questions, actually. I've, of course, got millions of questions, but I've got the luxury of being able to work with you for the next 3 years on this, so it will be a bit greedy of me to ask you questions now. I've got a sort of couple online as well, but very much encourage audience members to ask. I can see 1 or 2 hands going up here. If I just take the lady here, and then I'll come to you in a moment, Rick.
I'm Adil Magdok, I'm a member of Common Futures Conversations, and it's literally the same question I asked yesterday. So we know that it's really important for communities to be healthy in order to prevent like pandemics and so forth. But what is the Commission looking at doing for countries such as mine, South Sudan, that contributes only 1% of its budget to healthcare? Like, what will be the incentives for the government, or also what levels of accountability will there be as well? So.
Right. So what advice might we have for South Sudan, which currently I think is a very low budget allocation? I think one of the lowest in the world, if I'm not mistaken. What can we sort of advise there in terms of encouraging the President and Minister of Finance to take health financing more seriously?
Well, 1% is obviously extremely low, and it's 1% of quite a low budget as well. So it's very, very, very little indeed. I think the key message I have is that you cannot prosper as a society and economy if your people don't have access to the most basic health services. You know, on 1%, there'll be nothing like comprehensive access for women to sexual and reproductive health services, and that right to bodily autonomy, to make your own choices, to have safe birthing, your children to be born and have the most basic support from the beginning. 1% isn't going to cover that. There's just so many things that it's not going to cover. So I think, South Sudan, if it can reach a level of stability, because the conflict has been devastating for the health of people in South Sudan, needs to see providing or giving priority to these most basic elements of a public health system as a priority, as part of its rebuild for its people. And that, as Rob said, is a political decision. President Kiir and his Vice President need to see that this is something that has to be top priority. And if that's the case, then investment will flow from that. And South Sudan at peace is fundamentally not a poor country. It sits on an awful lot of oil, right? Now, okay, we're going into an energy transition, so that's not going to work forever. But right now, if you've got peace and stability, you've got the money. And so, peace first, health next, I think would be my message. But President Kikwete is still online with us, and he's a sort of neighbour down the coast, as it were. I'd really love to hear his perspective, if he's able to give it, on how South Sudan could see access to basic and universal health as a critical thing coming out of the situation it's been in.
Yeah, sure. I'm not sure. Do we still have President Kikwete on? I know that he had...
popped in a minute ago.
Oh, there you go. Yeah, President Kikwete, your perspective from Tanzania, maybe even sort of relating this question to Tanzania, that you've had various health reforms in Tanzania over the years. I mean, do you see potentially there being an opportunity in Tanzania to accelerate progress to universal health coverage?
Well, of course, first on the question of South Sudan, of course, I've been involved with the leadership of South Sudan for some time now, trying to see what can be done to bring peace. At the request of President Salva Kiir, I worked on because in the view of President Salva Kiir is that the crisis started within the party SPLM. So I think the divisions within the SPLM is what really has precipitated the crisis that is ongoing. So at some point he asked me to see if I can help bring together the various divisions within the SPLM, come together and say dialogue. So I hosted all the factions in Tanzania at Arusha. Well, I think for a good 4 or 5 months, they sat down, they discussed, and then came up to an understanding of how to bring together all the factions, and then unify the party, and then from there it is possible to be able to get the peace that they wanted. Because they did that for some time, and then I think bad blood again stepped in, interfered, and things erupted again. So I think in their situation of war, they spend more money on defense and less on health. But I believe if they get peace, they would be able to allocate the resources properly.
Yeah.
But again, it's a political decision for leaders to decide on how much it. Because when I became president, the health budget was, I think, six down the line. So I had agreed to take deliberate action and brought it to third, because the first line is education, and then we had infrastructure, and then so we brought in health as number three. It's really political decision. It's a political decision at the highest level. If there is that decision, then there's going to be more spent on it. Of course, you can spend more money, but spending it on what? That is the challenge. Of course, in our part of the world, the first problem is really access to health facilities. When people have to walk distances to access health facilities. And this is, in part, it contributes to high maternal mortality rates. Because I have a practical experience. When I was member of parliament, one day I was in a meeting in one of the villages, and a huge mango tree, as we always do it here. And on the road, just 500 meters, about 200 meters away, I saw people pulling a bicycle. Behind that bicycle, there was a huge bamboo basket and somebody in there. So after the meeting, I was then driving the same direction. We caught up on the way, and we stopped and asked what was wrong. I said there was a mother there who has been having labor pains for the last 2 days, and now they were taking this mother to the hospital. They had already done 12 kilometers, and the hospital itself is 20 kilometers away. So then what I did was just, I told everybody, let's come out of the car, let my car take the lady to the hospital, and then come back for us. So you find these kinds of situations that really people need health care, but the access to the facilities is another problem.
Yeah.
At the facilities, the health professionals is another challenge. Availability of medicines is another challenge. So really, when we talk about universal health coverage, it is about health facilities being available, health professionals being available, and medicines, and the necessary medicines being available. Of course, then we, with, as I mentioned in my speech, with the structural adjustment program, the introduction of user fees, now there are people who can't even have the money to see the doctors. So that is where now, when we talk about universal health coverage, really, what do we do about this? Those who can't afford, how do we make a health available? So that is where now universal health insurance, the health insurance has to be put in place. But even with health insurance, you have to be able to pay. So there are a number of challenges, but I'm sure through this panel, these are some of the issues that we're going to discuss and come out with share experiences and see what can we do so that people, even those, the poor, the underserved, the underprivileged, can also have access to healthcare, which is a basic human right.
Yeah. Absolutely, and we have the ability for people to share lessons from the countries. Some countries will do some things very well and others less well. One of those that, say, Estonia, I think, is the best in the world on health information systems. And we have a wonderful NHS here, but I don't think that we're particularly proud of some of the information system reforms we've had here over the years. So each country brings different things to the party. I've just got time for one more question. And Rick was first with his hand up there. I don't want to be rude to our next panel, so I'm afraid I'm just going to have to. There's just in the front here, the gentleman with the glasses here.
Perfect. Thank you so much, first of all, for sharing all of your insights. So my name's Ritvij. I'm a newly qualified doctor and also an intern at Chatham House. And my question is, how do you convince finance ministers that they can afford health reforms? And the context being that a lot of the countries that need universal health reforms now have a big debt financing problem off the back of COVID. And a lot of them will say the short-term debt financing is the priority, while the benefits of health reforms come 3 years, 4 years, 5 years down the line, and they can't afford it today. And we mentioned the Thailand example, that the World Bank told them it might not be a good idea to fight universal health reform. So in the face of these challenges, how do you convince these finance ministers that it's the smart call to make?
Excellent question, Rick.
Well, I think that countries in such a position need a recovery plan. In fact, really everyone needs a recovery plan right now, resetting from COVID and then also taking on board the lessons of how we're exposed globally to the Ukraine crisis, which has these devastating impacts on food supply, energy prices, poverty, hunger around the world. Inflation, 9% inflation in the UK. These are catastrophic rates of inflation that countries haven't seen in the West for a long time. So in the recovery plan, yes, address things sequentially, but put health in the plan, because the health of people has been greatly damaged by these crises, and the climate crisis will keep on raising the risks to health, including for the poorest and most vulnerable countries. So I think you raise the issue of debt financing, which is a completely different discussion in a way, but when the G7 meet, let's hope they say something meaningful about the debt stress that many countries are now under. The tools which the IMF had to sort of try and help with the debt servicing burden through COVID didn't help a lot, to be honest. And there is now a major issue again of debt stress. We've been through rounds of alleviating debt in developing countries in the past, but the need is there again. And yes, you're right. Unless we can get on top of that, it's going to start crowding out everything that needs to be done: universal education, universal health, universal basic social protection. We're talking here specifically health, but around 4 billion of the world's peoples lack access to the most basic universal social protection. And that hurt during the pandemic as well. Because it's our last minute, Rob, I just want to make one more point. Often when people talk about essential services, it's a very, very narrow definition. And talking on the side, Rob and I are talking about, it needs to be access to the full range of services. And one of them is access to essential controlled medicines, which is made not easy by the International Narcotics Control Board and the scheduling of drugs. But 85% of the world's people lack ready access to essential pain relief. And I think, in our lives, we all know people who've suffered unbearable pain through cancer or other issues, which needs access to controlled medicines. 85% of the world's population does not have that. Mm-hmm. And you can think of the agony of being in a terminal illness or the chronic back pain or whatever and not having it. So, let's think quite comprehensively about the issues here. It's not just what some consider the basic core, it's a broader issue than that.
And that tackling those problems is often outside the immediate health sector. It does involve the Ministry of Finance and the head of government and an all-government approach. So I think that's a very important point there.
And if I could just
Ulana,
add
please, if you come in and President
very
Kikwete.
Practically, when it comes to South Sudan, civil society can put a lot of pressure on government, and that's how it happened in Ukraine. In 2014, there was a revolution of dignity, and there was a big upsurge of civil society. They were the ones that pressured Parliament to create a strategic advisory group, which then advised us on how to do healthcare reform. So civil society is very important. And then secondly, we often used European Union membership as an excuse why we had to do all kinds of reforms. Some of them aren't even written in the plan, but we would say, oh, we have to do this because it's a requirement for European Union integration. And people would not read the plan, so they didn't know the difference. And so sometimes you do have to use requirements of outside institutions to force your government to do something. That worked. Then when it comes to finance ministers, we sat down with our finance minister and we showed him, it was a him at the time, we showed him how much of the money was being lost through corrupt practices and how much of the money could be saved and redirected at actual health care. So we didn't change the percentage of financing in health for the first year. When he saw how efficiently things were being run and how much better it was and that it was successful, then they started increasing by a couple percentage points the amount of money being spent on healthcare, because we proved ourselves that we weren't just asking for money to continue the same inefficient practices with corruption, but that we were actually creating better services, more access to services, and it works, so results work. And the last thing, when it came, we also had the same problem with physical access to healthcare facilities in Ukraine, because about 40% of our population lives in villages, and it's anywhere from 20 to 40 kilometers to the nearest hospital. So we included in our primary health reform that each of the primary care facilities has a vehicle, and that vehicle is for the use of the primary care facility. They can either drive out to the village to see the patient, or it's used as a medical taxi to bring patients back. We also included in hospitals not only regular ambulances, but transport ambulances, who could then again drive out to the healthcare, drive out to the villages to pick people up and bring them back when it wasn't an emergent situation, but somebody just needed transportation. So there are ways that you can include that into your healthcare. You just have to figure out how to make it work. And we had a lot of help from the World Bank and World Health Organization, and financing from USAID, UK Aid, and others that would give us those small perks that really helped the primary care physicians and the patients be satisfied with what we were doing. So there was a very high satisfaction rate once the implementation started.
Super, thank you very much. President Kikwete, have you got a 10 seconds last thoughts?
There was a good question on how do you convince the Minister of Finance. At one point, I also have been a Minister of Finance. And first, you must understand, everybody goes to the Minister of Finance. Those in transport, in health, in education, and everybody. So the Minister of Finance has a lot on his plate. And how much to allocate to each one becomes a problem. I think the answer when it comes to healthcare or any of this section is the political decision of the head of state, head of government. That was.
Yep.
If the president decides that allocate more for health, the Minister of Finance will allocate more for. A negotiation between the Minister of Health and the Minister of Finance may work, but I think at the end of the day, if the head of state, head of government gives education and health the priority that it deserves and decides that more money should be allocated, I think that's why I think a decision at the highest political level is what is going to turn around the situation.
Yep.
I think that's a perfect way to finish the session, actually. And this is very much the idea behind the Commission, that our target audience for these discussions, heads of state, and maybe even people vying to become heads of state. And of course, this is a very, very political process. So thank you very much indeed. That was absolutely wonderful. And please, everyone, do get involved in the Commission. And particularly, we're looking for people to talk to about this. So if you know of anyone vying to become head of state who wants to run on a universal health platform, please do get in touch with us. Thank you.